test done there at your doctor and have the results in no more than 15 minutes. Dr. Steve Hahn will be here tomorrow to talk about progress in evaluating Abbott Laboratories' point of care test. Also, speaking of the FDA, on the subject of swabs, the FDA did announce earlier this week that testing symptomatic patients by swabbing from the front of the nose is perfectly appropriate, and it's already begun across the country. It allows for self-collection, and it also relieves the burden on healthcare protection. It saves personal protective equipment from being expended when people can administer a test themselves. And Dr. Birx will speak about the importance and the availability of swabs. With regard to supplies, you heard the President speak about what we have already shipped out from the National Strategic Stockpile. More than 9 million N95 masks for healthcare workers, 20 million surgical masks, 6,000 ventilators, and millions of gloves and gowns and face shields. In addition to that, we are working with a number of suppliers to manufacture ventilators, even while we work with state leaders to assess not just what ventilators are available in their state hospitals, but what ventilators are available in private hospitals across their state. And governors across the country are doing great work evaluating the full supply of tens of thousands of ventilators that are available. Let me also say thank you to the American Society of Anesthesiologists and Dr. Mary Peterson. The American Society of Anesthesiologists actually produced a video. Tomorrow they will host a webinar for healthcare workers to demonstrate how the devices that anesthesiologists use can be very easily converted into a ventilator that's appropriate for a patient struggling with respiratory ailment like the coronavirus. And we're very grateful. This actually adds tens of thousands of devices to the supply, and we're all truly grateful to Dr. Peterson and the whole association for their full cooperation. With 5 of 10 counties in the country being the top counties for coronavirus being in the New York City metropolitan area, let us reiterate our recommendation that any resident of the greater New York City area who has traveled elsewhere in the United States, please check your temperature, mind your health, and self-isolate for 14 days. What we don't want, again, with 5 of the top 10 counties for coronavirus being in the greater New York City area, we don't want anyone, and no one would want to, inadvertently carry the coronavirus to a community or to a family member inadvertently because they've come out of that community. So again, as Dr. Fauci said recently, if you've come out of New York over the last several weeks, before the mitigation measures are put into effect in particular, check your temperature, mind your health, and self-isolate for 14 days. It is inspiring as I prepare to introduce Dr. Birx to talk about the data that we're monitoring on a regular basis, and Dr. Fauci to talk about mitigation. Let me conclude by saying how inspiring it is to see the way America and the American people are responding to this moment. We all were awakened this morning with record unemployment numbers, not unexpected during the time of national crisis that we are facing. But what you may not know is that while there were some 3 million plus new unemployment claims, Walmart announced they're hiring 150,000 new associates through the end of May. Amazon, a few weeks back, announced they're hiring 100,000 additional warehouse employees to meet a growing demand at Amazon for online purchases. CVS Health is going to provide bonuses to their employees working with patients and hire 50,000 workers. And Pizza Hut, I'm told, is planning to hire more than 30,000 permanent employees. And that's just a short summary of a list that totals almost 500,000 jobs that have been announced by businesses around America. And it's not just been about jobs, it's been about generosity. Anheuser-Busch is making a $5 million donation to the American Red Cross to support first responders. OYO Hotels is offering doctors, nurses, and first responders free rooms at any of their 300 hotels all across America. And the pharmaceutical company, AbbVie, is actually donating $25 million to the International Medical Corps and to Feeding America. American businesses are stepping up to partner with us to meet this moment, but they're being incredibly generous as well. to all of those that are stepping in the lead and providing healthcare services, and of course to those most in need. We can do this, America, but it'll take all of us. As the President often says, we're all in this together. But as millions of Americans do their part, with 15 days to slow the spread, putting into practice the President's guidelines for combating the coronavirus and its spread, we grow more confident every day that this too shall pass with the cooperation and generosity and prayers of the American people. I just know that we will slow the spread, we will protect our most vulnerable, and we will heal our land. And now for information on the latest on data and what we're seeing, Dr. Deborah Birx.
Thank you. Thank you, Mr. Vice President. So just as a summary of where it looks domestically, I won't talk so much about the global issues at this time. We do have 19 out of our 50 states, to be reminded, that had early cases but have persistently low level of cases, and at this point have less than 200 cases. So that's almost 40% of the country with extraordinarily low numbers, and they are testing. Some of our governors have been very adamant about their need for test kits. We have gotten them test kits. When we had Abbott add about a week ago to the test kits, we've been able to open up additional test kits for states that want to do surveillance and want to do contact tracing. These 19 states are doing still active containment. They're at 200 cases despite the fact that they've been measuring them over the last 3 to 4 weeks. Still, though, 55% of all cases and 55% of all new cases continue out of the New York metro area. That's the New Jersey part and New York part in particular. I haven't added in Connecticut or other counties at this point. We are concerned about certain counties that look like they're having a more rapid increase. When you look at Wayne County in Michigan and you look at Cook County in Chicago. So we have integrated all of our information to not only look at where the cases are today, but how they're moving, so we can alert FEMA to where we think the next potential hotspot is. All of the counties that I've mentioned, the hotspots are in urban areas or in the communities that serve that urban area. And I think that's something very important to remember as we move forward. Because of the innovations within our private sector, we continue to have these new platforms added for laboratory testing. And these become critical platforms for states that have very low rates and very low rates needed to test. Why is that important? Some of these machines have wells and plastic plates that, in order to be effective, you have to put on about almost 96 samples. And others are made for 4 samples or 24 samples at a time. So what's critical for us to be able to do is to match the need to the county and state. And that's the role that we can provide advice on, because we get to see across the whole country and where those items are needed most. And so this is allowing us to adapt and adopt really allocation of tests or recommendations to state of what piece of equipment they may need. Of the 550,000 tests, you can do the math, but we're still running somewhere about 14% overall. That means 86% of the people with significant symptoms, because remember, you had to have a fever and symptoms to get tested at this point. So still 86% are negative. These are really important facts for the American people. I'm sure many of you saw the recent report out of the UK about them adjusting completely their needs. This is really quite important. If you remember, that was the report that said there would be 500,000 deaths in the UK and 2.2 million deaths in the United States. They've adjusted that number in the UK to 20,000. So 500,000 to 20,000. We're looking into this in great detail to understand that adjustment. I'm going to say something that's a little bit complicated, but I'm going to try to do it in a way that we can all understand it together. In the model, either you have to have a large group of people who are asymptomatic, who've never presented for any test, in order to have the kind of numbers that were predicted. To get to 60 million people infected, or of 6 million people infected, you have to have a large group of asymptomatics, because in no country to date have we seen an attack rate over 1 in 1,000. So either we're only measuring the tip of the iceberg of the symptomatic cases, and underneath it are a large group of people. So we're working very hard to get that antibody test, because that's a good way to figure out who are all these people under here and do they exist. Or we have the transmission completely wrong. So these are the things we're looking at, because the predictions of the models don't match the reality on the ground in either China, South Korea, or Italy. We are about 5 times the size of Italy. So if we were Italy and you did all those divisions, Italy should have close to 400,000 deaths. They're not close to achieving that. So these are the kinds of things we're trying to understand. Models are models. We're adapting now to the reality. There's enough data now of the real experience with the coronavirus on the ground to really make these predictions much more sound. So when people start talking about 20% of a population getting infected, it's very scary. But we don't have data that matches that based on the experience. And then finally, the situation about ventilators. We were reassured in meeting with our colleagues in New York that there are still ICU beds remaining, and there's still significant, over 1,000 or 2,000 ventilators that have not been utilized yet. Please, for the reassurance of people around the world, to wake up this morning and look at people talking about creating DNR situations, do not resuscitate situations for patients. There is no situation in the United States right now that warrants that kind of discussion. You can be thinking about it in a hospital. Certainly many hospitals talk about this on a daily basis. But to say that to the American people, to make the implication that when they need a hospital bed, it's not going to be there, or when they need that ventilator, it's not going to be there. We don't have an evidence of that right now. And it's our job collectively to assure the American people that it's our collective job to make sure that doesn't happen. Right now, you can see these cases are concentrated in highly urban areas. There are other parts of the states that have lots of ventilators, and other parts of New York State that don't have any infections right now. So we can be creative, we can meet the need by being responsive, but there's no model right now, no reality on the ground where we can see that 60 to 70% of Americans are going to get infected in the next 8 to 12 weeks. I just want to be clear about that. So we're adapting to the reality on the ground. We're looking at the models of how they can inform, but we also are learning very clearly from South Korea and from Italy and from Spain. Just a final, because I know many of you will look up my numbers. The only people who are over really 1 in 1,000 cases are people that have very small populations, like Monaco and Liechtenstein. So you will see a different number coming from when your population is really tiny. One case can put you over 1 to 1,000 or 2 to 1,000. Thank you.
Good. We'll do questions in a moment. Dr. Fauci.
Thank you, Mr. Vice President. I'm going to change the topic just a little bit because there was a questions that came up, and I've been asked about this on a couple of media interactions regarding the interventions that we're talking about. And it's important because it's about something that I said yesterday about what we would likely see. Whenever you put the clamps down and shut things down, you do it for 2 reasons. You do it to prevent the further spread, this we call mitigation, but you also do it to buy yourself time to get better prepared for what might be a rebound. It may be a rebound that we get things really under control, and then you pull back, which ultimately we're going to have to do. Everybody in the world is going to have to do that. You're either going to get a rebound or it might cycle into the next season. So what are we going to do to prepare ourselves for that? One of the most important things is one that I mentioned several times from this podium, and that is to clarify a bit about the timeline for vaccines. And would that have any real impact on what we would call a rebound or what we would call a cycling in the season? Certainly, for sure, a vaccine is not going to help us now, next month, the month after. But as I mentioned to you, we went into a phase 1 trial, and I keep referring to one vaccine. There's more than one. There's a couple of handfuls of vaccines at different stages of development, but they're all following the same course. And the course is you first go into a phase 1 trial to see if it's safe, and you have very few people, 45 people within a certain age group, all healthy, none at really any great risk of getting infected. And the reason you do that, because you want to make sure that it's safe. Then the next thing you do, and that takes about 3 months, easily, maybe more. So that's going to bring us into the beginning or middle of the summer. Then you go to a phase 2 trial, or what we say 2-3, which means we're going to put a lot of people in there. Now, we hope that there aren't a lot of people getting infected, but it is likely there will be somewhere in the world where that's going on. So it's likely that we will get what's called an efficacy signal, and we will know whether or not it actually works. If, in fact, it does, we hope to rush it to be able to have some impact on recycling in the next season. And like I said, that could be a year to a year and a half. I'm not changing any of the dates that I mentioned. But one of the things that we are going to do that you need to understand that has been a stumbling block for previous development of vaccines, and that is even before you know something works, at risk, you have to start producing it. Because once you know it works, you can't say, great, it works. Now, give me another 6 months to produce it. So we're working with a variety of companies to take that risk. We didn't take it with Zika. That's why, we have a nice Zika vaccine, but we don't have enough to do it because there's no Zika around. Same with SARS. So that's one of the things we're really going to push on, is to be able to have it ready if, in fact, it works. Now, the issue of safety, something that I want to make sure the American public understand. It's not only safety when you inject somebody and they get maybe an idiosyncratic reaction, they get a little allergic reaction, they get pain. There's safety associated. Does the vaccine make you worse? And there are diseases in which you vaccinate someone, they get infected with what you're trying to protect them with, and you actually enhance the infection. You can get a good feel for that in animal models. So that's going to be interspersed at the same time that we're testing. We're going to try and make sure we don't have enhancement. So the worst possible thing you could do is vaccinate somebody to prevent infection and actually make them worse. Next, and finally, with regard, I'll get you to your question. Finally, with regard to therapies. I mean, we keep getting asked about therapies. There's a whole menu of therapies that are going into clinical trial. As I've told you all, and I'll repeat it again, the best way to get the best drug as quickly as possible